Hello and welcome. In today's episode, we have Professor Salim Surani with us, who has been here with us multiple times. So we are very, very thankful for his time. Last time when we talked to him, there were some trials were coming along in terms of COVID-19, some new medications, and it's looked like in last several weeks since we have talked to him, probably over a month ago, a few of these results have come out. So welcome, Professor Surani.
Likewise, thank you.
Thanks for being here. We'll just cut to the chase. And can you share with us what has been update since we last talked to you? I think it last talk we had it in May, and now it is almost in the end of the June. So, what has come up in some of those new, some of the clinical trials, and then some older drugs which have shown some promising results or not? So, please walk us through.
One of the things I must say that the science is moving at a record pace. We have never seen such pace in our life. It's a very fluid status. This is a virus which came as a novel virus, and we are trying to learn and trying to throw everything under the armamentarium. And obviously, we know that not everything is going to be successful. We started initially with the hydroxychloroquine, then we know that it wasn't showing some benefit, and then some benefit, and then we knew about the side effects. There was some controversy related to that, but lately, just very recently, the NIH actually even stopped the ORCID trial. So in other words, that was a closure on the hydroxychloroquine. Then we had some discovery. We talk about remdesivir coming in, and that was one of the medicine which was used to treat Ebola virus. And initially there was a small study, and then the NIH study came in, and that was a very promising study. It has more than 1,000 people, and we saw almost 29% reduction in the mortality rate. And this was very, very beneficial, especially when the patients were sick. So you give a 200 milligram first day dose and then 100 milligram daily for 10 days. And they saw improvement in the mortality and also time to discharge from the hospital. And in other words, the patients who were sick were also getting benefit, as well as moderately ill patients were getting benefit. Then we start seeing some of the other data coming out with the triple therapy, which was published in Lancet. We briefly talked about it, that lopinavir and ritonavir, which was a HIV medication, when they use in combination with ribavirin and beta interferon, and that shows improvement in the progression of the disease, decrease the viral replication, and show some efficacy in the prospective study. Then I think since then we have come across some new medicines, and you probably know that there was a medicine which is used for the rheumatoid arthritis treatment, baricitinib, that was very widely used in the Australian region as well as Russian region, and we start catching up on that. So there has been, if you look at the baricitinib, which is again cytokine inhibitor, just like what we have seen the interleukin-6 inhibitor like tocilizumab, which we're using it very significantly in our patient based on the small pilot study. Now there is a major trial going on sponsored by the NIH where they're using is actually a combination of remdesivir and baricitinib. So this is like, what you're doing is you're giving a 200 milligram of a remdesivir IV on the first day, and then 100 milligram daily for 10 days. And then you're using a baricitinib in an oral pill 4 milligram daily for 14 days. And they're trying to enroll almost 100 centers in US and around the globe. So that is the study going on, and we hope that it can show some even more promising results, and that would be, again, a randomized controlled trial. So that will show some light on what is happening with that. And if you look at it, baricitinib, which is, again, cytokine inhibitor, and that actually acts by the pathway of a JAK inhibitor or Janus kinase inhibitor. So this is a medicine which we have used in the rheumatoid arthritis patient. So I think, we are trying to form every combination of therapy. There has also been some trial going on with a monoclonal antibody. We have some trial going on with the GM-CSF. So if you look at the trial, there are lots of medicine being tried on, and that has been showing some progress. Let's come and take a little bit turn in what's happening with the convalescent plasma. You know that the Mayo Clinic, which has organized the largest trial and involved like hundreds and hundreds of institutions around the country, and they have tremendous data on usage of enormous number of the patient. And what they are showing it in their data that they are showing a mortality rate of around 14.9% in a patient who are very, very sick. So again, I think it's one of the challenges that they're just showing a 7-day mortality rather than a lot of the other trials are showing 28 days mortality. So if you look at some of your your registry data, I think it is showing in the ICU mortality somewhere close to around 25 to 30%, depending on the region, especially in the patient who are getting admitted in the ICU. And you're reporting and seeing in the basis of 28 days mortality, whereas the convalescent plasma is showing almost close to 15% mortality, but that's a 7-day mortality. And we know that a lot of the patients, maybe if you pull it through 28 days, that number will go up to 20, 22, 23. We don't know that. The second challenge with the convalescent plasma is basically there is no control now. So you just are giving it to the patient who are very sick, and then you are comparing it with some of the other propensity match control, but there is no randomized trial. So that is one of the biggest challenge with the convalescent plasma. But the advantage of the convalescent plasma is it's very readily available, and it is also can be done in a lot of the developing countries, uh, like India and Pakistan and Africa. A lot of those places, people have those machines, they have the capacity because they always have the blood banks which are collecting the blood and the plasma, so they can actually have the access of those therapies. So from the uh, logistic point of view, I think the convalescent plasma is making a lot of a stride. It's a cheaper therapy, availability is there in different regions of the world, and the production is not that very much of an issue, but again, that is one of the therapy. So in other words, we try to sum up like a lot of the trials which are going on since we talked last time. So I think if you look from the promising thing, what is holding, a couple of the things, I'll come to it in a second, what are holding. But another thing which has shown a very significant benefit was the dexamethasone or a steroid. And that was the initial report came back from the British group, and they sent out a press release, and now it's in a preprint, but it hasn't been kind of paper has not come out, so we don't have the complete information, and we need to dissect those things out. But one of the thing is that the dexamethasone, what they were using it in, is like a 6 milligram daily dosage, and what they found was in a patient who are really sick, they found a significant improvement in the mortality. And that is a very, very interesting finding, because in our practice, we have been using this steroid. We have been using solumedrol rather than dexamethasone. And we, from the very word go, we have been using the steroid. We have been using the anticoagulation, as well as we have been using vitamin C, kind of a little modification and variation from the METH protocol. But again, those were not proven therapy. So initially, when we were using the anticoagulation, we start discovering that when they were having hypoxia, and then they realized from the autopsy specimen from Mayo Clinic, from the Mount Sinai, that they were having a lot of micro and macrovascular thrombi. So the role of the anticoagulation become more prominent based on if your D dimers are elevated, then you can go into that. Steroid was WHO recommendation was that the steroid was not beneficial, and they actually recommend against that. Our feeling was that we have used the steroid in combination with convalescent plasma, and our feeling was that every patient we were using, we were seeing whoever was sick coming to the ICU or whoever was in the oxygen, we were seeing the benefit. Our feeling was that there is a point where WHO was kind of not really up to the pace, and we needed more information. But since we were seeing clinically beneficial, we used. And when the dexamethasone study came in, I think it was it was having a good feeling that we saw some. But on the other hand, people who are very uh, minimally sick, uh, someone who is not on oxygen, they're doing good. They actually saw some. They did not see much benefit, and even a little bit higher mortality. So we really need to look at the data, what the data comes out. From our practice, we mainly see the patient who are really sick. So when we have used it, we saw some beneficial effect. So now coming to the point, what are the approved or some of the therapies which have shown in a good response? We obviously have a remdesivir, which came in with the NIH double-blind, actually placebo-controlled trial. And then second thing is a dexamethasone study, which has come in and showed benefit. Now coming to the other therapies, we have the convalescent plasma, which has shown some improvement in benefit, but again, there is no blinded study, so we have to take that with caution. Then we have seen some beneficial effect with the JAK kinase inhibitor like baricitinib. Then we have seen the benefit with the triple therapy, and now there is a combination therapy going on with the NIH-sponsored trial with the remdesivir and baricitinib. So I think we have made a long way and trying to complete with the cycle, but a couple of the therapies are totally kind of out, which is hydroxychloroquine is kind of out. The adjuvant therapy, I think there's a lot of momentum about the vitamin C, somewhat with the vitamin D, and some of the other adjuvant therapy. But again, we have not seen any conclusive randomized controlled trial to see the effect. There's a math trial going on. There are several centers involved in that. We hope and see what the result shows, because if the result comes and show that, they have one of the very cheap medication. So to sum it up, I will say we have a remdesivir, we have a dexamethasone, we have anticoagulation, and we have a convalescent plasma to go with that. And a lot of the other things, whether you take a monoclonal antibody, GM-CSF, and all the other medication which I've mentioned, they're still undergoing through the trials.
Excellent. You just spoke in one breath, and then you were well aware that we had Professor Varun there last few weeks ago. He was talking about Math Plus protocol as well, and he's shown some impressive results as well. So, as a clinician, if I ask you to take a step back, it's now almost 3 or 4 months since you have seen the whole spectrum. Uh, Things started from hydroxychloroquine to combination therapy, Math Plus, remdesivir, convalescent plasma, now dexamethasone, and so on and so forth. Some clinicians would say that it's not a new syndrome, it's not a new diagnosis. Or yes, patients are getting infected with coronavirus, but the process is similar. It is a little worse than what they have seen it. It is a little quicker in that sense. So if you take a step back and think about, are we forgetting, or are we paying more attention to neurotherapy in comparison to the basics of clinical treatment, what you would do for sepsis, infection control, and lung protective mechanical ventilation, or a recognition of shock and providing early therapy? So any comments in there that we should not, should we look for that magic medication, or should we focus on the basics of critical care in early hours, which you and many of your colleagues have championed over the years?
Let me tell you, it's a very interesting point you have raised it. One thing you must have, we must say that, it has only been 3-4 months, and how many studies and papers have come out and has been published. It's just unbelievable. You know that the review process sometimes takes 6 months to 1 year. And, I have one paper with going on with a study for 3 years and going through all the processes and review. It's been 4.5 years and we still are submitting. So if you look at a lot of the studies we have been involved, major trials that take 4 to 5 years before it see the daylight. Here we are going in, and within a matter of days and weeks, we are seeing some of the results and publications. So yes, there is a lot of the thing. Now coming to the thing is that why is it a new syndrome, or is it something different? One of the thing is that in this disease, we don't have the handle of why somebody gets infected and have no symptoms, why somebody gets the infection and develop mild symptoms, and why somebody gets infected and develop very severe symptoms. So in the beginning, we had the classification that somebody who has a chronic illness like COPD and diabetes and some immunosuppressive disease, or even in the children, like some chronic illnesses, and they develop PMID syndrome. But what happened was that we don't know that why then now we are seeing a lot of young people are getting infected and they are doing very, very poorly, and they have no health symptoms before that. So this is one of the very, very tricky scenario that we have not been able to do that. There was one study where they look into the SERP protein as a marker, and they realize that people who have that SERP protein marker, they actually have a much higher incidence of severity of the disease and somebody who doesn't have. So in other words, they're trying to find it, like if 10 people get infected, who are the 1 or 2 people who get very, very sick and we need to act aggressively, we need to start the therapy early, we need to pay attention on a very, very small, minor detail, versus we know that, a lot of the people are not getting sick and they're doing good. And that is one of the biggest challenge we run into it. People become complacent. We know that the silent carriers are the biggest challenge we have. Almost 46 to 50% of the testing which has been done in some of the centers have shown that the patients are asymptomatic. So they have no symptoms. And again, that is a very, very interesting question. So that is very different. We know that when the patient get the infection, they get a sepsis, they all follow the same course, and we know that that is where they're going. And the COVID, I think, is very different because some patients are very asymptomatic and some patients are looking good, and then all of a sudden they go down very, very fast. So it's not like sepsis, you have the golden 3 hours and golden 6 hours or first 12 hours here. The patient may be looking good for 3, 4, 5, 6 days, and then within a matter of hours, they decide to take a southward turn. And the happy hypoxia theory came in, a lot of those theories came in.
Absolutely. Well, thank you. Any what would be your take-home message from this last 10 minutes interaction for our viewers, for our young clinicians or those who are watching this?
Keep your eyes out open. Follow your institutional protocol. There may be a differences in institutional protocol depending on what studies or trial you're involved. But for the basics, I think, if the patient is sick, think about the anticoagulation, think about the steroid, and think about the remdesivir. And if they're very sick, think about the interleukin inhibitor, whether you use a tocilizumab or baricitinib, and the convalescent plasma. I think that is what we have in our armamentarium besides supportive care. Try not to rush into intubating for just the sake of intubation. If they need intubation, just by your regular parameters, do that.
Perfect. And you did mention we are aware of that one of your publications are coming out soon when we are you have written about novel and controversial therapy. So we look forward for that publication. And thank you so much for being with us. We know that we'll be bringing you back to talk about our second wave as coming in and what your thoughts are. So we will definitely bring you back for that part. For our viewers, it was a privilege to have Professor Surani in his busy time. Thank you so much for being with us. Please do subscribe to our channel, like, and write in comment section what we can record for you. And we'll be come back with Professor Surani and many more speakers. Thank you, Professor Surani, once more.
Thank you.